name is Dr. Musa Shimonki, and I am excited for the opportunity to represent our center, FSAC, on behalf of men having babies. Thank you all for coming to my talk at 3 o'clock. I really appreciate that. So, as you know, Men Having Babies is an outstanding organization which educates and brings important resources such as egg donors and surrogates and reputable reproductive lawyers and access to reputable clinics like ours for you that attend the meeting. Now, I'm particularly excited because my partner used to work in San Francisco and we had a 7-year long distance relationship. So I got to know this city very well. I live in Los Angeles, but San Francisco really is my favorite city in the world. And every other weekend that I'd come up to visit, we'd go running down to the farmer's market along the Embarcadero, and that's exactly what I did this morning, actually. This is a picture from this morning. I ran all the way up, saw the Golden Gate Bridge, took a picture, ran back, and went to the lovely Embarcadero Ferry Building, got a lot of yummy treats, and bringing some back home, and then came back to the conference. So, you are well educated. You've thought this through, that you're not newbies to this. And I'm just going to very briefly discuss the basic steps moving forward. And we'll get into more and more detail as the talk progresses. But you are here because you want to have a child. And how do you get there? Well, how do you get from point A to point B? And basically, there are multiple steps. And we'll talk you very briefly through each one. Of course, there's the initial evaluation. You would then choose a donor and then a surrogate, or whichever direction you want. Usually you start with the donor first so you can create the embryos, and then a surrogate to carry that baby or babies for you. And then fingers crossed embryo transfer to help things hopefully work out the very first time. And then the journey through the pregnancy with your surrogate. As you've heard many great discussions already, and the panel discussion earlier this morning was really wonderful, hearing real life journeys for people. And we'll go from there. So of course, what you need to accomplish task A to baby is, of course, we need your sperm. And the first question is, whose sperm? You know, are you both going to be involved in the process? Is one of you going to be involved in the process? Are you going to keep it unmasked where you both know which embryo is created by your sperm, or do you mix them together? And there's pros and cons of each approach, of course. Of course, we then need an egg, and then the third part is the uterus. And the uterus via the surrogate that makes you feel the most comfortable. So I love to get to know all my patients. I want to know every detail about their history because my goal is to treat each and every individual that comes to our clinic like they're my family, like they're my brother, my sister, my loved one, my friend. And so we take a very detailed history for each of you, and there's a physical examination. Of course, there's a semen analysis. We want to make sure that there are no issues up front. And there's some blood tests involved as well in preparation to create those embryos. And this is very routine, very standard. It's actually required by the FDA. So we follow the latest and greatest guidelines that are told to each of us. Now, the one thing that a lot of clinics are doing now, which we were on the forefront of doing many, many years ago, is offering genetic carrier screening. It used to be that egg donors were not screened. Most of the egg donors nowadays are screened, and we also offer genetic carrier screening for the intended parents as well. And we'll get to that in just a second. Very briefly, this is what a normal semen analysis looks like. You've probably seen these numbers, but if you haven't, that's typically what your doctor is looking for. And then we help you find the ideal egg donor. Now, this can be very complicated because each person has their specific journey as to what they want. Some people want one child, some people want several children, and that alone may dictate which direction you go, what you choose, and whom you choose for a donor. It is less expensive to use frozen eggs. It's also less likely to work because you're working with a smaller sample size of eggs. So if your goal is to have one child, the most cost-effective way to go may be to choose an egg donor. If you want multiple children, the most cost-effective way to go may be to go with someone you choose to go through a fresh IVF cycle just for you, where you could have multiple embryos in the end, hopefully, and that'll improve your likelihood of having multiple children and building your family the way you wish. So we help you find reputable agencies. We do not work with one specific agency because we don't think that's fair to you. We like working with any reputable agency to offer you the widest options available for both egg donors and for surrogates, and we'll get to the surrogates in a second. And we work with all the reputable egg banks as well. I believe California Cryobank is now the biggest egg bank in the world because they just recently bought out Donor Egg Bank USA and have become, now the biggest egg bank, but there are many reputable egg banks out there. The goal is to get you at least one, if not more than one, healthy baby. So I talked about universal donor genetic carrier screening. This also applies to you as well. We do recommend carrier screening because we want to make sure that your baby is born not inheriting 2 abnormal copies of a disease. Because if that baby does inherit 2 abnormal copies of that disease, that child will have the disease. These are mostly what are called autosomal recessive mutations. I don't know if you could go all the way back to your biology back in high school or before, but this is very simplistically broken down. If one of you is a carrier for a particular mutation, that doesn't affect you at all, but if the donor is as well, there's a 1 in 4 chance of having a child with the disease. Our goal is to pick that up beforehand so that you don't end up with a baby with the disease, and we help guide you through this process. And this is just a quick example of, for cystic fibrosis, which is the most common mutation out there, it's actually, there's a pretty high frequency depending on which ethnic group you come from, but just about anyone in any society can carry cystic fibrosis. Nowadays, the genetic carrier screening can test for anywhere from 200 to almost 400 mutations, and more isn't necessarily better. It's very personalized, so some people just want to test the most common and most disease-significant mutations. Other people want to know, hey, am I a carrier for anything? And I just want to make sure, if I am, that the donor is not, and vice versa. And there's no wrong answer. It's whatever is best for you and your journey. We also work with, as I was mentioning earlier, all reputable surrogacy agencies. We do not do a quid pro quo where we work with just one or two, and I would advise you to consider that might be a red flag, because the goal really is to offer you the broadest number of options. And there's differential pricing, there's differential types of service, and so really you want to choose what's the best fit for you. And we work with anyone who is reputable. Of course, the surrogate is medically and psychologically screened. I personally screen them all, and I take a very careful look at everything, not just the history, the physical examination. We very carefully evaluate the uterus. There are some red flags that may be very subtle that you'd have to be very careful to identify that might reduce your chance of getting pregnant. We want to pick that up front and make sure you have the healthiest possible outcome based on the history and the physical examination. So these are the guidelines in general. The American Society of Reproductive Medicine suggests no more than 5 total prior deliveries, and depending on what you read, no more than 2 to 3 C-sections. There's a subtle abnormality in women who've had C-sections that a small subset of surrogates might have that might lower your chance of, if you use that surrogate, of getting pregnant. So we look very carefully for that. And there are many practitioners out there that don't even know this entity exists. It's called ismicele for anyone who's had a C-section, where the fluid backs up into the uterine cavity, and that can actually lower one's chance of implantation. So we look for all these things very carefully. So these are the typical uterine abnormalities we look for: polyps, fibroids, scarring, and infection, as well as the ismicele that I was telling you about. And there's a very specific time that you want to look for all this, either on birth control pills or before you've ovulated, if the surrogate is ovulated, because something like a filling defect like a polyp may not be as clear if the surrogate is already ovulated. So we always bring them in either in the first half of their cycle or on birth control pills where these abnormalities might stand out more. And then we further perform not just an ultrasound, but what's called a saline ultrasound to make sure the polyp stands out amongst some dark fluid on the ultrasound. And we also biopsy the lining to make sure there's no chronic infection. Also an emerging topic that a lot of places don't check for. We rule that out up front. Now, if you have chosen frozen eggs, this part's already done. The donor's already been psychologically screened, has already gone through the process of taking the medicines, their eggs have been retrieved and then frozen. But if you're choosing an egg donor for you where they're going to go through the process, I'm going to talk very briefly about the stimulation and the egg retrieval. So there's a very specific set of hormones that we give the donors that normally a donor has many eggs available and naturally the body selects one to grow and ovulate. We kind of override that system to allow us to retrieve whatever number of eggs they have available at that time to grow, and then we retrieve them. And then the medicines that we give not only stimulate the ovaries to produce all these eggs, but then the trigger injection that matures the eggs is specifically designed to mature the eggs beautifully and then very quickly shut down the ovary so that the donor does not get sick. There's a syndrome called ovarian hyperstimulation syndrome that high responders, donors or high responders, are at risk for. We make sure that donor is safe. We make sure we give the right types of medicines to minimize risk to the donor. Also, the way we do the egg retrieval is done extremely carefully, where I generally poke each ovary just one time. I was very fortunate enough to train at a high volume center at Cornell in New York City, where at the time we did the most IVF cycles in the country. And it was just an unbelievable experience and allowed me to look at how people did things differently and tailor the way I do it, where I felt it was maximizing outcome but minimizing risk, and that's at every single step. And so what I've learned is you can get every egg, with rare exception, from each ovary with just one poke. So you poke the ovary once, you put the needle in the follicle, it collapses, and then you go right on to the next one while you're within that ovary with just that one poke. And you poke one side, the other, and you get all the eggs that way with minimal trauma to the donor. And that minimizes the risk to them. So anyway, this is just a schematic of what an egg retrieval would look like. And that egg is microscopic, so we're just taking the fluid out. And you get an egg from the vast majority of follicles, not every single one, but most of them. A mature egg under the microscope looks just like that. It just looks like a circle, nothing inside. And it's mature because it's extruded half its genetic material in that little thing called a polar body. And the reason why it does that, it's preparing for receiving the other half of the DNA from the sperm. And so it divides actually twice. It puts out the first polar body, and when the sperm enters again, it puts out a second polar body, dividing again, so it's down to that half number of chromosomes to merge with the sperm to create the full complement for the baby. Now, oftentimes, it depends on depending on what the sperm looks like, you can mix the sperm with the egg, but also just to ensure that fertilization has occurred, the egg is held by the pipette, and as you can see right there, and then you can microscopically pick up one sperm that looks the best. This is all done in the laboratory by our fabulous embryologist. You can inject one sperm into each egg to fertilize the egg and create embryos. Now, an embryo looks like this, and the egg is fertilized because it has the genetic material from both the sperm and the egg. By each circle there, the two pronuclei, each one contains the DNA from the female, and one contains the DNA from the male. And within just a few hours, that merges together and becomes one. Really, really neat. But that's a sign of fertilization. It's called 2pN. That's the day after the egg retrieval. This is a couple days later, and this is a couple days later the blastocyst stage. And this is where we can safely test an embryo if you want to do genetic screening on the embryo to test to see if it's a male or female and if it has the right number of chromosomes, which we'll get to briefly. Now, thankfully, we live in an era where the media has improved to allow us to grow out these embryos, and the freezing techniques have improved dramatically. Now we lose less than 1% of embryos with the freeze thaw. So when we retrieve eggs, not every egg will fertilize. And in the old days, people used to pick one of these day 3 embryos. But you had less precision and less ability to pick the right one. And also, if you did genetic screening at this stage, there was potential harm to the embryos. So now, we grow the embryos out a couple days later, but still, embryos can look great. But let's say, for example, 2 of them are abnormal, but 1 is normal. We can take it a step further and genetically screen those embryos, where we take a sample of the cells destined to become the placenta, and we can screen them for the correct number of chromosomes, and if it mattered to you, male or female. So as I was mentioning before, there used to be slow freezing. It's evolved to vitrification. We were early adopters of this, and we've been doing it since it existed to maximize the chances of embryos and eggs surviving. So back in the old days, the slow freezing would cause fractures in the egg and the embryo, and the structure would not survive, but vitrification allows for virtually every embryo to survive that process. So now, once you've created your embryos, you choose your surrogate, and the surrogate takes hormones to build the lining, basically estrogen to build the lining to make it thick and ready, and then when you add progesterone, that starts the clock. On the 6th day of progesterone, the implantation window opens up to allow for reception of an embryo, assuming that embryo is normal and will stick. And so we, tailor that specific to the surrogate and your embryo. So you've heard numerous people talk, and quite frankly, there are many good centers here, but why choose me and why choose Fertility and Surgical Associates? So I'm a little unique. I had the great fortune of growing up in a family of my father being a reproductive endocrinologist, and he was the first fellow at UCLA back in the late 70s. And my father inspired me every single day and taught me from a very young age that reproduction is a right for all and that everyone deserves to have a baby. And his patients absolutely adored him, and he was the kindest, he's still alive actually, he's the kindest man you'll ever meet. And he'd come home every single day happy, and I was like, I viewed medicine as that. In fact, I tried not to copy him, and I kept OBGYN down at the bottom of the list, and it just kept working its way up. But basically, right before he retired back in 2007, I had the opportunity to work with him after I came back from Cornell, and it was really one of the greatest opportunities I've ever had in my life, right before he retired. And this is about 10 years ago. My kids here are in their teens, but this is a picture of my kids with my parents there. So reproduction is a right for all. And this lesson, as I was mentioning, was taught to me by my father, and it's motivated my passion for helping anyone, and I mean anyone, seeking fertility treatment. And this is why I'm so honored to be here today. We have outstanding service, exceptional outcomes. I invite you to call our office and schedule a financial meeting so you can talk about that, and affordable care. And this is our staff. We have a great staff. These are my wonderful, ethical, transparent colleagues. We are honest. We treat you all like family, from every single staff member to my colleagues. And we have a 5-member team specifically dedicated to third party, but if you include the international team, it's closer to actually 12, 13 people. And our website is designed also not just for local patients, but internationally and for the LGBT community. We have a cutting-edge laboratory. Dr. Weiwa Wong is internationally known and has outstanding pregnancy rates. And basically, we have mastered every single step of embryo biopsy, if that's what you choose to do. And this is PGTA, is what it's now called, genetic screening of the embryos, where you can detect abnormal pluses or minus of genes, and you get a report. And I'm sorry, I'm doing this a little quickly because it looks like they're about to pull me here. And we could also check for monosomic diseases as well. So our outcomes are outstanding. I invite you to go to sart.org and look at clinics. Don't take people's word for it. People will say, I have 105% pregnancy rate. Go to the website. They hold clinics accountable. If they don't report to SART, I'd also question that. So please take your time, and I really hope to see you someday soon. We'd love to help you build your family and start your journey. So anyway, let me just go to my last slide. Oh, one last thing, which is very important. We transfer just over 1 embryo per patient. 9 out of 10 patients get 1 embryo, and that's because we feel very strongly about not only maximizing outcome, but minimizing risk. We treat you like we would treat me, like we would treat my family.